Pathology of Tuberculosis (TB). Tuberculosis (TB) is a chronic infectious disease caused by Mycobacterium tuberculosis and acid-fast bacillus. It primarily affects the lungs, pulmonary TB, but can also involve other organs, extrapulmonary TB. Below is a detailed explanation of its pathology. 1. Causative agent. Mycobacterium tuberculosis, a slow-growing, obligate aerobic bacterium with a lipid-rich cell wall, contains mycolic acid, which makes it resistant to desiccation and many disinfectants. 2. Mode of transmission. TB is spread through airborne droplets when an infected person coughs, sneezes, or speaks. 3. Pathogenesis. A. Primary infection. When inhaled, M. tuberculosis is phagocytosed by alveolar macrophages. Immune evasion. The bacteria inhibit phagosome-lysosome fusion within macrophages. This allows them to survive and replicate intracellularly. B. Granuloma formation. The immune system attempts to contain the infection by forming granulomas, components of a granuloma core. Infected macrophages, multinucleated giant cells, and necrotic debris caseation. Peripheral layer, lymphocytes, T cells, and B cells, and fibroblasts. C. Latent TB. In most immunocompetent individuals, the infection is contained and the bacteria become dormant. D. Reactivation TB. In immunocompromised individuals, latent bacteria may reactivate, leading to active TB. Reactivation often occurs in the upper lobes of the lungs, where oxygen tension is higher. 4. Histopathological features: case-eating granulomas, central area of necrosis surrounded by epithelioid cells and Langerhans giant cells. Ziehl-Neelsen staining. Acid-fast bacilli can be visualized as red rods. Fibrosis and calcification. Healed lesions may show fibrosis and calcification gone complex in primary TB. 5. Clinical types of TB. A. Primary TB. Initial infection, often asymptomatic or mild. Gone focus lung lesion, plus gone complex lung lesion plus involved lymph nodes. B. Secondary reactivation TB. Occurs when latent TB reactivates. Affects the upper lobes of the lungs. Symptoms: cough, hemoptysis, night sweats, fever, and weight loss. C. Extrapulmonary TB. Involves other organs, for example, lymph nodes, scrofula, bones, Pott's disease. CNS. Tuberculous meningitis. Abdomen. Intestinal TB. 6. Immune response, innate immunity. Alveolar macrophages engulf the bacilli. Adaptive immunity. CD for plus T cells secrete interferon gamma, IFN gamma, activating macrophages. Effective macrophages kill bacteria, while ineffective ones allow bacterial growth. Cytokines, for example, TNF-alpha, IL-12 play a crucial role in granuloma maintenance. 9. Treatment. Combination therapy to prevent resistance. First-line drugs: rifampin RIF, isoniazidine, pyrazinamide PZA, ethambutol EMB. Duration: 6 to 9 months. Drug-resistant TB. Requires second-line drugs, for example, fluoroquinolones, bedaquiline.